connect and to collect data, but also fell in a COVID year. So I've got reflections on how that has impacted and what I've learned as a result. So my mentor is Dr. Annie Horan at Leeds Beckett University, and I did the internship through Sheffield Hallam University. So it's not going to let me move, is it? It might just be a delay. I have moved my slide on, I think. Yes, here I am. So in about 2018, we started to look at delivering voice therapy via telehealth in Rotherham. Little did we know a pandemic was on the way, but we started preparing for a pilot service delivery project that ran from April to December 2019, where we used Microsoft Teams to deliver synchronous live therapy via video consultation, and then we used various apps that you can use within Teams to support therapy between sessions, and used a variety of apps to make that happen. I'm going to move on. And really, we were doing this, and as we were doing this, I went to the Newcastle Voice Conference in 2018. And there was a presentation there by Professor Paul Carding on telehealth in speech and language therapy. And during that conference, I realised from that talk that the evidence base for telehealth in speech and language therapy, and particularly voice therapy, was very small. I also realised that we were doing it already, and thought what I'd better do is collect some robust data from our project that was shareable. Because of that, I applied to the NIHR internship, and what that allowed me to do really from September 2019 was to look really deeply at the evidence base for telehealth and the use of apps in therapy, particularly related to voice therapy. It allowed me to plan my study and also do my ethics application, which I totally underestimated the time that it was going to take to do this. But the evidence base that I was able to gather allowed me to put this table together. And this is just a summary of some systematic reviews into the telehealth evidence base in speech and language therapy for adults and paediatrics. But I would say that what I noticed as well was that the majority of the studies were based in the States or Australia, I would say predominantly. Not so many in the UK, and not loads in the NHS, which was what I was interested in really. So looking at the evidence overall, I sort of collated the benefits and the challenges. This is certainly not an exhaustive list. This is just sort of a summary, because we couldn't really put like 140 papers into a table. So, but overall, I mean, a lot of us will have adopted telehealth during the pandemic, and in terms of the benefits and challenges, I'm sure these are also very familiar to a lot of you. So we know that it reduces time and cost and travel. Cost in this instance was related to the American healthcare system, probably reduced time off work. Studies have found that goals have been met, relationships have been established with clinicians, and that acoustic parameters for voice, which is what I was looking at as well, can reliably be measured with smartphones for patients to be able to send those remotely, and that really assessment and therapy outcomes have been comparable in trials, pre-pandemic trials, and there are real transferable skills, a lot of potential ways for new working, which we will have seen in the past year, and that there were studies that really said there's no negative impact on rapport, and overall clinician experiences were positive. And in terms of challenges, these are probably things that we recognise as well. So the need for physical support with technology, people struggling at either end, not being able to be close to the people that we're working with, reduced provision of hands-on care, so in the case of voice, so laryngeal manipulation and that sort of thing. And also a challenge can be that it requires different communication methods, although with speech and language therapists, I think we are well placed to overcome a lot of these barriers. So, but what about during COVID? So this was a nice study that looked at in the States, looked at speech therapy, occupational therapy, and physiotherapy via telepractice during COVID, and surveyed and interviewed patients who'd experienced that. And again, those benefits were and limitations were very similar to the evidence base from before, in terms of being able to involve people at home. They had benefits to particularly children, to having a familiar environment, but also that people were just very appreciative that their care could continue during a pandemic. Lots of people said they'd like it as an option in the future, but they'd prefer a mix of face-to-face and telehealth. And one thing the authors just queries is does that satisfaction with telehealth increase compared to non-pandemic times because of that appreciation of continued care in some form when services are limited? Which is an interesting question. So in terms of what I did in my NIHR internship time, I was capturing the patient's perspective on face-to-face versus telehealth for voice therapy, and really to explore their perspective and to seek their views on future developments. Obviously, this was pre-COVID. So the impact of COVID on my research journey, because until I went to the Newcastle Voice Conference, I didn't have a burning research desire, but then I saw a problem and I thought, actually, this would be a really good thing to put time and energy and funding into, just to see how we can change our services for the future. But as with many people, the pressures of work and home, that nice carved out day that I had every week to do stuff, got mixed up with lots of other things, childcare and work pressures. I had applied for my ethics just before, and my approval got a bit delayed because of the onset of lockdown last March. There were lots of times throughout last year I thought, oh my goodness, I thought I'd have analysed this data by now. But the skills that were very timely to have in a pandemic were that I had sorted out pre-pandemic, the governance issues related to telehealth and therapy. We had resources, we had the technology in place, and we had the remote therapy experience. And during the pandemic, I was able to collect my data, which is a miracle. What I'd spent most of my internship doing was getting ethics approval. This is just a visual image of what that looked like. And one of the things that when I got the approval, mainly because in March when it hit, and I thought, well, I submitted it 6th of February, I'd resubmitted all that they wanted and then heard nothing. So I emailed the Research Ethics Committee to say, in my research protocol, I can interview my participants remotely. It's already in there, and I think it's relevant to COVID. And I got approval within 24 hours, which was great. So I was able to do that. But one of the things I kept querying before I resubmitted it was my role as a clinician and a researcher and somebody who is approaching my own patients. And they really wanted clarification on that. And I guess that sort of delay in resubmitting gave me a chance to reflect on that, on my role within that. And I just thought, am I a hindrance in this study? Do I need to get somebody else to come from outside to interview people where I've been involved in their care? And this was a good quote that I found about health and care workers conducting research might be perceived as having more power in the research relationship than if they had not been practitioners, and ensuring participants have and perceive themselves to have adequate power to determine their role in the research is ethically necessary in practitioner research. I also had a couple of quotes from patients, one where I was just looking at how I was going to conduct my interviews, and one of my potential participants said, it's better if you're interviewed by someone you know. I certainly feel more comfortable that way. You know that they know where you're coming from. And another quote from a patient who I've only ever seen via telehealth for voice therapy. She said, I think the power balance is different with remote consultations. When you come into a hospital, you know where the power lies and it isn't with you. This way, I feel like I'm inviting you into my front room and it's more equal. So I've just found these really interesting, really inspiring, kind of blur the boundaries sometimes of how research ethics works in terms of how maybe it's not always easily set up for qualitative research. I don't know. But, so these were the ways that I felt with my study I could reduce the negative impact of being a clinician and a researcher. So in terms of analysing things collaboratively, getting research ethics committee approval, making sure that people have completed all of their therapeutic intervention, all the information that you give out. I've secured some funding to get gift vouchers, which helps differentiate it from previous intervention, because I don't regularly give gift vouchers to my patients. And those interviews took place outside of the clinical environment where they were all remote. And this quote as well, I felt gave me a bit of hope for the value of me being involved in research. Just that the qualitative researcher cannot be an objective bystander collecting data in a personally disinterested fashion. They should become immersed in their work and be aware of the emotions it evokes and the presence and impact of their personal values. And so I've got a table here that I won't go through all of it, but just it made me think, well, what are the challenges and then what are the opportunities? And it gave me a chance to just reflect on my role within it all. I think there are a lot of opportunities. I think obviously there's challenges in terms of bias and a thorough knowledge of their therapeutic and medical history. But I think if you've got an approved and a transparent research protocol that you're following, I think the communication skills that I've used for therapeutic reasons totally transferred to the research interview. And I think just switching my focus so that they're the expert in their lived experience of voice therapy and telehealth. I mean, I am part of that lived experience for the ones who receive therapy from me, but that established therapeutic relationship, I feel, just got a lot of information quickly and in a lot of depth. And that power imbalance, I think I don't, it would be interesting to know if they felt that, but it did feel very different. They weren't in my clinic room. I was at home during a pandemic for one. So, and I think that understanding of the subject matter, that deep understanding as their therapist, I think that really helped to prompt effectively in interview. And I just decided to approach it like I didn't know them and to be willing to explore and be surprised by the data. I mean, yes, I have a vested interest in this service delivery method working, but to be honest, the pandemic did put all of that up in the air, and it was like starting all over again. So all was not lost during COVID. Because of what we'd already done on the ground, we could rapidly extend the service to our head and neck cancer patients across our MDT with our allied health professional colleagues. My colleague was seconded to go and work in health informatics out of her speech therapy role because we'd done it for so long and we're the only ones in our trust who had. And I think our contribution within our trust to help other people and support them to roll out telehealth and knowing what the evidence base was really valuable. We were able to help myself and my colleague Rebecca Davies help the RCSLT write the telehealth guidance and do a webinar, and also have developed a remote dysphagia risk assessment tool for dysphagia assessments, which is on the RCSLT website. And again, just having a thorough knowledge of the evidence base pre-COVID to be able to apply to clinical tools that are going to be useful on the ground has been a real privilege and such a massive benefit. And also because of my role as both a clinician and working in informatics and technology, I was accepted as a member of the Faculty of Clinical Informatics, and there are huge numbers of speech therapists in there, so that was really great. So I think although my research project did not quite go as planned, and I will present some findings and we'll be at some conferences later in the year as well, but I do feel that the value of being a clinician and a researcher on the ground changes practice quickly, I think. And I think our networks for sharing it and seeing it applied quickly, I have seen that sharing and that collaboration, and I really feel that we are needed more than ever. And these are all my references, and thank you very much for listening, and I'm very happy to answer any questions and also be contacted outside of this meeting.
Thanks so much, Rachel. That was excellent. It was a really interesting reflection of the last year and your work before. I think what really struck with me was that that you saw a problem and that's what your research addressed. And I think that's, you know, it's always really motivating, isn't it, to do research which you feel is really relevant to your role and will make a change for you as well as your patients.
Oh, I'm on video.
Yeah. I think the other thing I thought as well was that you know, sometimes with literature reviewing, we sort of think, oh, it's not the most interesting part sometimes, you know, or maybe not maybe as fun as data collecting, but actually the benefit of the literature review and knowing the literature, and that might be something that, you know, kind of clinicians can be doing, you know, even kind of before they've maybe secured research funding and things. So some really good tips, and certainly about the reflection. I'll open it up to people to see if they have any questions for you. I will need to see. Yeah, I think I can access the chat, but you might be able to access the chat as well. I don't know if anyone has any questions for Rachel.
I've got a question. I know I'm a panelist as well, but while everyone's thinking about the question, can I chip in?
Go for it.
Yeah, please do.
I really loved what you said about not having a burning research desire, but just spotting a problem that needed addressing. And I thought that was such a brilliant quote. I'm going to pin it up on my wall. And as someone who's on that clinical academic trajectory as well, I think that's it. I never saw myself as an academic or a researcher or someone who wanted to do a PhD earlier on in my career, but it was that just seeing problems and questions and wanting to find out more about them and know what the best way to find out about them was. So in your experience of doing the internship, have you got any other sort of pearls of wisdom or gems, things that you've learned, or any ideas about what your next step might be? Have you spotted any more questions that you feel might need to be addressed?
Yeah, I think, yeah, definitely. Because I think when I started the internship, I said, here's what I want to find out. I want to know about experiences. I want to know about outcomes. I want to know this. I want to know that. And basically, one of the people leading that course said, well, you've just literally described a PhD. So, you know, that's how long that's going to take you to get all of that information. And I was really surprised. But also, I would have said, oh, no, I don't want to ever do a PhD. I've seen people do a PhD. So it's very time consuming. But that just made me think, oh, so maybe the purpose of research isn't to get doctor before your name. Because when I did my master's to train to be a speech therapist, I remember saying, well, I'm not doing that again. But I think when you see value in it, when you see clinical value in it, it just changes what you think a PhD is, or what you think the next step is. And I think I've just decided, initially I thought, oh my goodness, I'm just overwhelmed at the potential career opportunities and what to do and what to do next and what to do with my time and what matters to me. And I think not rushing those decisions and those thought processes. I think the PCAF is the next step probably for me. I think I haven't finished what I'm doing, but my funding has finished. So that is my motivation to pursue funded time, which actually to have that protected time was invaluable. And I really enjoyed those days so much that made me think, well, I would be sad to lose them. So that was my decision-making process as to whether to pursue research further.
Great, thanks. There are another couple of questions in the chat, but I'm just conscious of time. So we'll move on to Sarah's presentation, which I have a sneaky suspicion will pick up on some of these things, which is great. And so you can reply in the chat if you can, Rachel, or I'm sure people can follow up with you.
No problem.
Later. So I'll hand over to Sarah. I'll turn my video off, and my car is now started. So hopefully I'll be back in my my room by the time I'm next on screen. So I'll hand over to Sarah for the moment.
Hi, thanks so much, Helen. And that was a great talk, Rachel. And I think my talk kind of follows on very neatly from what you were saying. So that's excellent. So the purpose of this talk is really to share some of my journey in research. So coming out of clinical practice, doing a research fellowship, and then coming back into clinical practice with some research elements. And I've deliberately chosen a picture of a somewhat foggy road with a hidden bend to sort of represent this journey, because as we know, there are no clear pathways yet for AHPs to get into clinical academic careers. To some extent, it is a journey into the unknown. Sorry, Kath, I can't put my slide on. Oh, there we are, I've done it. Okay, so this is a little bit about my research journey. And as you can see, I've put some roadblocks on it and a banner saying success at the end. And I think what I just want to emphasize is that, you know, there are lots of roadblocks that come and go, and there are also successes, and it's a case of kind of pushing through or finding a way around them. So I did a BSc to start with. I worked for National Environmental Research Council for a little while. Then I trained to be a nurse, worked as a nurse for a number of years. And when I had my family, I started doing some schools work for a while, decided to train as a speech and language therapist, and then, you know, discovered that there were these research pathways, and applied, and have been turned down. I was turned down the first time for my PCAF. I was turned down for CDRF funding, but it's a case of finding a way through. And I think it's important to kind of emphasize that so that other people are encouraged. So my research journey, as Kath was saying, started with an idea really, and a challenge stemming from my clinical curiosity. You know, why does the AAC therapy I introduce with families have such different results, and what's missing? So, you know, once we've got our clinical idea, how do we take that further? And one idea is to apply to a funded program. So this is the ICA program funded by the NIHR, and the level at which I was applying was the pre-doctoral clinical academic fellowship. And that kind of sits in between the internship that Rachel was talking about and the kind of PhD program, which is the next one up. And if you look at this slide, it looks like a really neat kind of program that you can follow your way through. But I think we'd all agree that it doesn't map very neatly onto clinical careers, and it doesn't map onto the kind of job descriptions of us as allied health professionals. So that's where the challenge lies really, in trying to kind of knit those two together. So this was my PCAF training. I took an MRes in applied research in human communication disorders at University College London. I did an introduction to systematic reviews and evidence synthesis at the University of York. I was meant to be presenting at some AAC conferences, but they've been postponed. They might happen this year, they might not. I did some clinical skills training, which again was impacted by COVID. And the other part of the program is to put together your applications for PhD funding. So this was the project that I conducted, exploring collaborative practice between speech and language therapists and parents of children who use AAC. As you can see, it was funded by the National Institute of Health Research. I was supervised by Dr. Michael Clark at UCL, and my host organisation is Oxley's NHS Foundation Trust, who I work for. So what do you do at the end of this? So I've just finished my PCAF programme, and you find that research changes you. You're not the same clinician as you were before. You're not the same person as you were before. And what do? Do we just go back into clinical practice? And what are we going to do with that knowledge that we've gained, and with all the networking that we've done? How are we going to apply that in the future? So there's some evidence from interviews from non-medical allied health professionals finishing clinical academic training, and participants said that they learnt to see themselves and their professional practice very differently. That everything they'd done was to enhance safe, patient-centred, clinically effective healthcare provision. But when they came back into clinical roles, they felt some role conflict, there was a struggle, they felt challenges to their identity, they had ethical dilemmas, and you know, all of these things were really impacting clinical academics when they returned to practice. So I certainly feel that I'm not the same person who started this journey 15 months ago with a clinical question. So, you know, the conversation I've been having with my managers all through was how do we as a service, how do I make the most of what I've learned? So I think it's useful just to look at this paper by Cowley et al. 2020. They looked at how to capitalise on early clinical academic training in allied health professionals, because it remains unclear how these skills and roles are being operationalised in a healthcare context. And they looked at the experience of early career allied health professionals in the UK. Now, the Association of UK University Hospitals plans to have 1% of non-medical allied health professionals holding these clinical academic roles with a part research role within their profile. And currently it's about 0.1%. So we still have a long way to go. And Richardson et al. Found that 50% of the respondents in their study reported inadequate support from their employing organisation as a barrier to their careers. And it was felt that sometimes funded research training was viewed as a transaction, which is kind of answering the question, what can I get from this? So, you know, if your service sends you on training to develop knowledge in an intervention, and then you come back and run the intervention, you know, a transaction has happened, and that's very clear. Whereas what this paper was suggesting was that we should view research training as a transformation. So 2 themes came out of the research paper around transformation, that people have an identity transformation, which changes their clinical and personal identity. So you have a new lens, if you like, in which to view your clinical practice once you've finished your training. And there's also the issue of operationalizing that transformation. Clinical academics seek out opportunities to critique their existing practice, to consider how practices and services could be changed and evaluated. So with all of this in mind, I started talking to my SLT managers quite early in the fellowship about what might happen next. And together we had a look at this framework, which is called Shaping Better Practice Through Research. And it's clinical research skills and knowledge framework. And as you can see, there's 8 domains there. And each domain operates at a number of levels. So it goes right from kind of beginner levels of knowledge about research up to research experts, really. So the levels of knowledge are awareness, core, intermediate, and advanced. And you can go through the framework and kind of score yourself as to where you think you are on each of those domains. And I think the great thing about this is that this framework helps to develop research careers at different levels. You know, it's not just for the research leader, it's for people at all different stages of their research journey. And it's important for all of us to be developing skills at the appropriate level. So just to give you some examples of some of those domains. So if we look at the research methodology and methods domain number 2, at an awareness level, which is kind of the base level, you would be able to differentiate between research, audit, and service evaluation. And then at the intermediate level, you'd be able to apply theoretical concepts and methodologies in relation to clinical research. So you can see how the levels build up and how the different aspects of practice are kind of incorporated into those. So the kind of outcome of us looking at this framework and having conversations and discussions about it was a 0.2 weight competitive post, which was funded out of the speech and language therapy budget, split between 2 paediatric services. So Oxley's, Bexley and Greenwich speech and language therapy services. And, you know, I'm incredibly grateful to the managers of both of those services for being willing to kind of take this step into the dark, really, and take a risk and really think about how we could build in an innovative post, which I applied for and was fortunate to be appointed to. And there are 6 requirements of this post, and each one has a set of outcomes. And these, as I say, are kind of based on the framework that I was talking about. So to develop awareness of research, I mean, that might be through organising study days and events, or, you know, signposting clinicians to different research activities that they can look at. Building capacity, which was around offering peer support for projects that are going on in the trust, setting up some working groups to look at different aspects of practice, and also sort of mentoring individuals who might want to apply for research funding themselves. Identifying stakeholders. So the great thing about this post so far is I've been able to network with people right across the trust that I would never have had access to, or, you know, didn't even know existed, frankly, before I started the post. So, you know, that's been a fantastic aspect of it already. So building the profile of this role, so networking more widely with groups of researchers and just raising awareness of it. And I hope that that will inspire others and help other trusts as they're thinking about these kinds of posts. And we can have a dialogue, which would be fantastic. And then planning and carrying out specific projects. So I've got a project on the go at the moment with the Communication Access Symbol UK team. And, you know, that's going really well. And it's great to be involved in a sort of wider project, which means I can network with people outside of the trust as well. And then finally, to evaluate the impact of the year. And we're kind of hoping that by evaluating the year at the end, you know, we can show that we can demonstrate that there is a real benefit in having posts of this nature for AHPs. So I think my message to you is, you know, this is quite a hard road. You know, sometimes it's been the hardest thing I've ever done. You feel like you're pushing a boulder uphill. And other times it's felt like you're standing on the top of the mountain. it's definitely challenging, but also incredibly rewarding. So I'd say to anyone who's considering it, you know, have resilience, look at all the feedback you're given and really carefully consider it, and just network with everybody and anybody who can help you and give you guidance. So I've put my details on here. There's my Twitter handle and my NHS email. I'm very happy to talk to people. I've had some emails already from people asking about the post, and I'll be getting back to them soon. And I'd really like to hear other people's opinions and hear about your experiences as well. Thank you very much for listening.
Hi, Sarah. Thank you so much for that. That was it was really interesting. It followed really nicely on from Rachel's.
It did, yeah.
And really inspiring. And actually, I think you put it really nicely about clinical curiosity. And I think that's a lovely term, you know, the idea that, you know, that maybe there's a problem, but also something that just interests you, and yeah, that time to reflect and go, actually, I'm doing all of this. Why is it different, or why is it the same? And really lovely to hear about your journey. And I think, you know, the reality of it, that sometimes it does involve rejection and trying again. And the other thing I thought, that the idea of feedback, and that, you know, I think we get a lot of feedback as clinicians, maybe in kind of peer supervision, but if you're not sort of yet in the research realm, there might not be opportunities for feedback. But that is where actually there may be people in trusts who are doing these kind of things that can have conversations, or, you know, there's some great networks now for for speech therapists. There's lots of active research clinicians and things like ResNet and the Clinical Academic Network and those kind of things. So that, yeah, to encourage people to sort of be proactive and seek it out is excellent. I really enjoyed that. Thank you. Does anyone have any questions? I'll see if I can have a quick look at the chat. Got a question saying, I'm wondering if you have any thoughts about how Clinac SLT posts fit with advanced practice and or consultant roles. And then there's a point there about networking during pandemic as well. Yeah, I think the impact of COVID, I think we've seen that in quite a lot of research presentations. So I'll let you take them one at a time.
Okay, so the first one, I'm not sure if I'm really qualified to answer. I think the answer would be that it doesn't really fit neatly at the moment, and that I think this is something that people are exploring, and I'm sure there are other people out there who are in those kind of consultant roles who would be able to answer that question much better than I can. But yes, I think the answer is that, you know, it's very individual in different trusts, and that different people have found different ways of putting that together. And I think quite often the experience is you end up with quite a portfolio career where you're doing different things on different days to try and keep your research and your clinical skills active. And I think that has its own challenges. But again, that's not really the level I'm at the moment. And I think, there'd be other people who are better placed to maybe comment on that. And I think the comment about COVID, yes, I mean, it has had, really significant impacts, but for positive and negative. I mean, one of the things I've been able to access is sort of international research groups throughout this period. And you just think, we probably wouldn't have got those research groups up and running, and we wouldn't have had access to that range of people from overseas if we weren't in the situation we're in now. So, there have definitely been positives in terms of networking, as well as the kind of negatives. I hope we'll get back to a situation where we can physically go to a conference and chat over coffee and meet people in a room. But I think, it's good to at least be able to online meet people from all over the world and discuss research with them. So yeah, it's finding the positives in a not very good situation, I think.
Yeah, and I think it's a good question in terms of that there's lots of virtual opportunities, but sometimes it can be things like, say, this for webinar, and there's a little bit of participation in terms of the chat, but maybe not that, kind of a face-to-face sort of in-depth conversations. And I think sometimes those can lead on from, say, things like this. So I've now sort of had face-to-face chats with Kath versus, that arose out of a Twitter conversation. Yeah. And things like, say, the RCSLT mentors, research mentors, that might be an opportunity where you can kind of speak maybe one-to-one, or the clinical academic SEM, there were some breakout rooms there where it was kind of smaller groups. So I can see that, there's lots of benefits of the virtual, but it's trying to kind of then make the most of those to get that sort of more interactive element to it. So yeah, it is I think it is about being proactive, isn't it? And reaching out, and you said people have emailed you and you're happily emailing back. So I think generally people are quite happy to be kind of approached, aren't they?
Yeah, I think they are.
And then, yeah, people have just said, oh yeah, so can you say any more about how you'll evaluate your role? Any measures you might be using?
Okay. So as I say, we put some outcomes into each of those 6 areas. So, I mean, we'll just start by looking at have we achieved those outcomes, and then I'd like to do some kind of wider information gathering, maybe about across the team about what they feel the benefit of the post has been, if there've been any personal impacts for them, if it's helped them, maybe develop an interest for research, if they've, I've had some sort of mentorship conversations with people who are interested in possibly, applying for funding. So I think it would be interesting just to get some feedback, really. But I think the main thing is to look at all the outcomes we put in the job description and just think, have those things been achieved? It's a year's post. You have to be realistic about what can be achieved one day a week in a year. But I think we've got some robust outcomes there that we can, can look at and say whether it's been achieved or not and what the benefit's been.
Yeah, fantastic. And certainly in my experience, speech language therapists seem to be able to manage and achieve an awful lot on the time that we have. So I've no doubt you'll be successful. So if anyone else has got any more comments or things, please do keep adding them to the chat, and Sarah can pick them up. So thank you very much. It was lovely to hear from you.
Thank you, Helen.
And we'll move on now to Claire.